Tea time's conducted simply because there's a problem called microvascular obstruction that occurs in about half of our patients that are treated with primary PCI. After the PCI procedure, we're usually pretty happy. We get normal flow in over 95%, and we're happy that we've done a good job. When we go on and we scan these patients with cardiac MRI, we find failure of myocardial reperfusion in about half of the patients. That's important because it's associated with adverse LV remodeling, so these patients have bigger ventricles, reduced ejection fractions, bigger infarcts, and it's associated with poor outcomes down the line, so increased risk of mortality and hospitalization due to heart failure. So it's common, occurring in about 50% of the patients, and there's no treatment for it at the moment. So there's a therapeutic unmet need there. So the rationale behind tea time was to randomize patients with high thrombus burden within 6 hours of symptom onset, so patients with potential salvage of heart muscle, and to randomize them after reperfusion to a therapy of intravenous intracoronary alteplase, 10 milligrams or 20 milligrams versus placebo. The feeling was that we could target the thrombus and these thrombus-rich laden arteries and reduce the obstruction to the microvessels. We've shown the results of that today at AHA, and unfortunately haven't shown an improvement in microvascular obstruction. It was a multicenter study, 11 UK centres. Our primary endpoint was microvascular obstruction, so that's a CMR endpoint. That was conducted at between 2 and 7 days. What microvascular obstruction is an area of hypoenhancement at the core of a bright infarct that we see on MRI. And that represents blocked microvessels essentially. So the gadolinium agent that we give as part of the MRI study can't perfuse to the core of the infarct. It was a randomized trial, placebo-controlled, 1:1:1 design, so placebo 10 milligrams or 20 milligrams of alteplase, and that was given as a slow manual infusion after we've reperfused the artery, but before we put in the stent, so trying to prevent distal embolization of clot, which we know is important in these patients with heart attack. So our primary endpoint, as I said, was microvascular obstruction. We find no difference in our primary endpoint between our placebo group and our treatment groups. If anything, there was a trend towards increase in MVO in patients who received 10 milligrams or 20 milligrams of alteplase. That wasn't statistically significant, but there was a trend to increase in MVO in those patients. We had a number of secondary endpoints. There was no difference in MRI-defined infarct size in our patients at 2 to 7 days or follow-up at 3 months. Ejection fraction was the same, as was LV volumes, but we did see an increase in troponin T area under the curve. So we checked troponin at baseline, so prior to reperfusion, and again at 2 and 24 hours, and we showed an increase in troponin in both treatment groups compared to placebo. Primarily, we can say that a strategy of intracoronary alteplase to patients presenting within 6 hours of STEMI is not effective. I think there's a clear result there. As part of a pre-specified analysis, we looked at ischemia time, and so that's the time from patient having symptoms to the artery being opened in the cath lab, and we find that those patients with longer ischemia time, so between 4 and 6 hours, there's a trend towards increase in microvascular obstruction in those patients treated with alteplase 20 milligrams. So I think moving forward, it shows us how important ischemia time is, and it shows us that in these patients with longer ischemia time, when there's been degradation of the capillary makeup, that things and treatments like alteplase have the potential to actually make things a little worse. Yeah, so I think there has to be future research. As we said, this is a common problem, and it's prognostically important. I think it can help in terms of the design of trials moving forward. We've touched on ischemia time already. A lot of these trials will include patients up to 6 hours and sometimes up to 12 hours. And I suppose when thinking about the designs of one of these trials, I would think carefully about ischemia time and the potential for harm when we're giving these potential treatments for benefit.